Welcome to Raaonline. I am Dr. Raaonline. Let's discuss this condition of acute appendicitis. Before we get into the acute appendicitis, let's learn or relearn our basic anatomy of appendix. Appendix is a worm-like cylindrical structure, and that's why it's called vermiform appendix. From the cecal fundus, it is very close to the ileocecal valve. It is on the posterior medial wall of the cecum, and most important thing is it is very variable in anatomical position. The various positions are retrocecal or retrocolic, pelvic, paracecal, subcecal, pre-ileal or post-ileal. Only constant factor in the whole anatomy is the base of the appendix, which is appendiculocecal junction. Continuing with this anatomy, the most important point to remember, it is supplied by an artery called appendicular artery, which is an end artery. It is a branch from ileocolic artery, the terminal branch of superior mesenteric artery. Lymphatic drainage is via ileocolic nodes and celiac nodes. Rectum and appendix are the only colonic portions with longitudinal muscles covering the whole circumference. Useful tip to identify the appendicular base during surgery is tracing the 3 tinea coli which will meet at the appendicular base. Histologically, appendix shows lymphoid tissue with germinal centers. Now coming to the appendicitis. This is the most common surgical condition all over the globe. The etiology is still not known. The etiology is still unknown. Complications of acute appendicitis is around 4 to 15%. Mortality of the disease is 0.2 to 0.8%, and it is almost 20% in people more than 70 years of age. Remember, the acute appendicitis happens in younger age group in their prime of life. The rate of perforation is about 16 to 40% in the young, whereas it's nearly 70% in the elderly. Coming to the pathophysiology, most of them start as an obstructive condition. The obstruction could be because of fecalith, worm or seeds. Non-obstructive could be due to hypertrophied lymphoid tissue. So, the obstruction causes increased peristalsis, which is the reason why patient presents with mid-gut colic around the umbilicus. Due to the horizontal collagen fibers, appendix cannot distend. So, the intraluminal pressure increases because of the obstruction, causing compression to the mucosa, which leads to ischemia. The spread of infection from the lumen and the microorganism invasion into the submucosal and muscular layer leads to acute appendicitis. So, absorption of the toxins and the necrotic products will lead to fever, tachycardia and leukocytosis. Now, the spread of infection transmucosally will reach this serosal layer, leading to serosal inflammation. So, contact with the parietal peritoneum of the inflamed appendix leads to localized pain in the right iliac fossa. Increasing intraluminal pressure leads to vascular compromise, leading to gangrene and rupture. So, clinically, the patient comes with a periumbilical pain, which is a visceral pain, mid-gut pain. It is colicky, non-localizing, and is intermittent severe pain. Then pain shifts to right iliac fossa, where it is localized, sharp, continuous pain aggravated by movement. Vomiting is the next important presenting complaint, happening almost in 50% after the onset of pain. Vomiting preceding the pain is a classical feature of intestinal obstruction, whereas after the onset of pain, the vomiting starts is a classical feature of acute appendicitis. Nausea is seen almost in 90% of the patients. Anorexia is seen nearly 80% of the time. Diarrhea some 20% of the time. Fever is a presenting complaint if the patient presents you late. You have to remember the symptoms are generally less than 24 or 48 hours. Patient is lying down still with the hip flexed because of movement and extension of hip can produce pain. Urinary symptoms including pyuria may happen if the appendix is close to the bladder or ureter.